No?
No.
We are live, please.
Okay,
So, good afternoon, everyone. On behalf of AI Scientific Committee, I welcome you all for this session, Module 9 of OPMS, One Problem, Many Solution, which is a part of video symposium. When the going gets tough, the tough get going. And today we'll be dealing with very important situation, Phaco in extreme short and long eyes. And I'd like to thank moderator of today's session, Dr. Komal Saluja, who is from CFS New Delhi, and Dr. Saurabh Luthra, who is from Bilaspur, Chhattisgarh. Thanks to speakers of today's session, Dr. Komal Saluja, Dr. Bhupesh Singh from New Delhi, Dr. Bharti Meghur from Bidar, Karnataka, Dr. Rajendra Prasad from New Delhi, and Dr. Atik Sheikh from Chennai. And thanks to our expert panel for today's session, Dr. Himanshu Mehta, who needs no introduction, from Mumbai, Dr. Abhijit Desai, a prolific anti-segment surgeon from Mumbai, and Dr. Bharti and Dr. Rajendra Prasad. So with this, I'll hand over to the moderator of today's session, Dr. Komal and Dr. Saurabh.
Hi, good afternoon, everyone. Thank you for kind introduction, Dr. Harshul. So as we all know, extreme axial lengths turn a routine phaco into a high-stakes surgery. Today's session is about recognizing where things go wrong and, more importantly, how to prevent them. So our opening batsman for today is Dr. Komal. A very brief introduction. She did her MBBS and MS from VMMC and Safdarjung Hospital, where she also did her senior residency. She's done a DNB as well and a FICO from UK. And she's done an advanced PG diploma in clinical research and medical writing from the James Lind Institute, Switzerland. She's currently working as a consultant for CFS Delhi, and she has many laurels to her armamentarium. She has also won awards for the best case presentation, ophthalmic quiz competitions, and ophthalmic photography. Over to you, Komal.
Thank you, sir. Thank you for the introduction and for this opportunity to share the screen with all of you. So, okay, so my screen is visible?
Yes, we can see that.
Hello, good afternoon, everyone. Today we will be discussing phacoemulsification in extremely small eyes and the associated risks and complications with them. Firstly, let's discuss what constitutes a small eye. Holiday classified eye into 9 types based on the axial length and the size of anterior segment. The biometric parameters to be considered here are the axial length of the eye, the anterior chamber depth, corneal diameter, and also the anatomical malformations. A small eye can be a simple or a complex microphthalmos, relative anterior microphthalmos, axial hyperopia, or a nanophthalmos. Axial hyperopia is defined as axial length of less than 21 millimeters with normal anterior segment and the size of the cornea, and also the anterior chamber depth is normal. Simple microphthalmos is defined as axial length that is 2 standard deviation less than the age adjusted mean, less than 20 millimeters with short ACB, normal scleral thickness, and no anatomical malformations. A complex microphthalmos is defined as all the pre-stated features along with anatomical malformations, that is anterior segment dysgenesis, iris or chorioretinal colobomas, retinal dysplasias, or persistent fetal vasculature. Relative anterior microphthalmos is an eye with a normal axial length, short ACD less than 2.2 millimeters, with a small cornea of less than 11 millimeters. In these eyes, the scleral thickness is normal and there are no other malformations. So the anterior chamber here is crowded and there is a high risk of anterior angle closure glaucoma, pseudoexfoliation, and corneal guttata in these eyes. Nanophthalmic eyes have a short axial length, less than 20 millimeters, a shallow anterior chamber depth of less than 2.2 millimeters, and a thickened choroid and sclera of more than 1.7 millimeters, without any other anatomical malformation. The incidence of nanophthalmos is almost 1 in 1,000. Now, these eyes are prone to angle closure glaucoma. As with advancing age and cataract formation, the lens thickness increases disproportionately to the anterior chamber depth. Incidence of angle closure glaucoma is 54 to 77% of nanophthalmic eyes. It may be due to pupillary block, plateau iris configuration, choroidal expansion, or a forward lens movement due to lax zonules. These nanophthalmic eyes are also prone to uveal effusions with exudative retinal detachment due to increased scleral thickness. Increased scleral thickness causes congestion of the vortex veins and consequent extravascular leakage. This, along with increased resistance to transscleral outflow of fluid, it leads to the accumulation of fluid in choroid, and it results in subretinal fluid accumulation. So before operating on small eyes, a meticulous planning has to be done. There is shallow AC, peripheral anterior synechiae, closed anterior chamber angle, and a normal or thickened lens occupying a disproportionately large percentage of intraocular volume. All this leads to a less space in anterior chamber to maneuver, and there is a high risk of suprachoroidal hemorrhage or a serous retinal detachment during the surgery due to this increased scleral thickening. There is a poor postoperative refractive predictability in such cases, and thus managing patient expectation is very important in these cases. You should inform the patient about the refractive unpredictability of the formulae and discuss the intra and post-operative complications that may arise during the surgery. Coming to the evaluation of visual acuity, short eyes are hyperopic, and high hyperopia with or without anisometropia has a high incidence of amblyopia. Visual acuity thus should be evaluated in detail. You should ask leading questions regarding the vision prior to the development of cataract, as the visual acuity may be low to start with. And managing patient expectations is very important in such cases, as post-operative refractive outcome may be low because of the anatomical malformations or because of the retinal dystenosis that is pre-existing and unrelated to cataract in such cases. So usually small eyes are hyperopic, but myopia may also be seen in these cases, which may be due to nuclear sclerosis. You have to look for anisometropia and ask for any past refractive history, any old records that are available. White to white measurement for corneal diameter has to be done. If it is less than 10 millimeters, it's microcornea. These measurements can be done manually, or you may use a pentacam or optical biometer for the same. These patients also have a higher incidence of corneal dystrophies. So a meticulous slit lamp examination should be done, and if available, a specular microscopy will help you evaluate the corneal endothelial thickness and also the morphology of the endothelial cells. Corneal pachymetry is also high. These eyes have thick corneas, so a corneal pachymetry may also come higher than normal. Next is the anterior chamber depth and intraocular pressure measurement. A gonioscopy should be done to rule out angle closure and peripheral anterior synechiae formation, as a high IOP with narrow angles have a higher risk of developing angle closure glaucoma. And a preoperative peripheral iridotomy in these cases, especially if peripheral anterior synechiae are present, will help in increase the anterior chamber depth and surgical maneuverability during cataract surgery. Evaluation of anterior segment dystenosis, colobomas, and retinal dystenosis should be done. Anterior segment OCT and UBM should be done, which may indicate a thickened sclera and a disproportionately large lens in a small anterior segment. So this can also help in measuring the scleral thickness in such cases. On ASOCT, 6 mm posterior to the scleral spur on the anterior scleral border. So this area, this is the scleral spur. 6 mm posterior to the scleral spur. On we have to draw a tangent on the anterior scleral border, and a perpendicular is drawn from this point to the posterior scleral border, and this thickness is taken as the scleral thickness. An ultrasound B scan in a short eye may be suggestive of a thickened sclera. In an anophthalmic eye may suggest a short eye with a thickened sclera. You may also see a multi-layered detachment pattern, which is very mobile when the patient moves the eye, suggestive of uveal effusions. You may also see an edematous anterior uvea with lacunae or cyst suggesting fluid accumulation in the course of the eye. Coming to IOL calculations, IOL calculations are very unpredictable in high hyperopia, especially if IOL power is more than 30 diopters. This variability increases to plus minus 1 diopter if IOL power is more than 30 diopters, and the patient should be aware of the chances of residual refractive error and possible need for more intraocular interventions. The variables that are needed for IOL calculations are keratometry, axial length, and effective lens positions. Effective lens position has a far greater effect on post-op refraction in cases of high IOL power, and the best formula is the one that predicts this ELP most accurately. Another important consideration is the relative size of the anterior chamber as compared to the axial length. In cases where the small anterior chamber depth is also short and axial length is also short, the IOL calculations are far more accurate when as compared to the normal anterior chamber with a short axial length. For axial length calculation, the most accurate method is partial coherence interferometry, an optical biometer, basically optical low coherence reflectometry. IOL calculation formula, third generation formula, Hoffer Q, which uses keratometry and axial length to determine IOL power and ELP. These works best for axial length less than 22 millimeters. We have new formulae like Holiday 2, which includes anterior chamber depth, wide to wide diameters, lens thickness, refraction, and age of the patient. And also a new formula is coming up, that is the Kane IOL calculation formula. This formula, there are multiple reports of this formula being at least as predictable as Holiday or Holiday 2 or Hoffer Q, and better than SRK-T in cases of short eyes. Also, when you are operating the second eye, your IOL power calculation can be refined on the basis of the postoperative outcome of the first eye. Another consideration, because these eyes have higher IOL powers, is to incorporate a single IOL, or you may need to use a piggyback IOL for full refractive correction. Also, you have to decide whether you are doing the surgery in a single stage or a two-stage procedure. Whether you are putting an intraocular lens and a piggyback IOL in the same sitting, or you are putting an intraocular lens in the back, and you evaluate based on the postoperative refractive outcome, and when you evaluate the space in the sulcus and overall how the eye is responding to the surgery, and then plan for a piggyback IOL to correct the residual refractive error in the second stage. So when you are planning for the single stage procedure, you can use a Holiday IOL consultant, which will give you both IOL powers for intraocular lens placement, also the piggyback IOL. Or if you are planning to do it in two sittings, a Nishaman normogram is used, which determines the residual refractive error and multiplies it by 1.5 to yield the IOL power to be placed in the sulcus. Okay, so discussion of surgical techniques will be done in the forthcoming presentations. Mainly, I'll just mention that a topical anesthesia is better than the retrobulbar block, which we may, we may plan if the eye appears deep set, but a topical anesthesia is better in these cases because a retrobulbar or a peribulbar block may increase the vortex vein pressure and may increase the chances of fluid accumulation. A preoperative mannitol, a temporal incision, cohesive viscoelastic, and a prophylactic anterior sclerotomy are the a few steps that can help with your surgery. I'll also briefly mention about the complications and postoperative management of the cataract surgery. These patients may develop severe anterior uveitis, which can be controlled by steroids. The risk of aqueous misdirection in such cases postoperatively is also high. Again, can be controlled with IOP lowering drugs, cycloplegics, laser hyalurotomy, or vitrectomy. Uveal effusions intra-op uveal effusions can be handled by performing a sclerectomy. And again, postoperative refractive errors can be corrected either by using glasses or piggyback eyes. So to summarize, cataract surgery on small eyes require meticulous planning and patient counseling, and a higher rate of complications and delayed postoperative recovery makes it very important for you to be familiarized with sclerotomy techniques, or you have a VR support if needed. And there are unpredictable postoperative visual outcomes and refractive errors, so good patient counseling is must. Thank you.
Perfect. Great. I think you've covered it all. Just one quick question to you, Komal, and then we'll probably go
Yes.
to the panelist as well. What is your strategy to avoid post-operatic hyperopic surprise in these patients?
So, hyperopic surprise is very common. Using a proper IOL calculation method is the best that we can do. Either Hoffer Q or Holiday 2. I have not used this Keynes normogram yet, but yes, Hoffer Q and a Holiday 2, matching the both results gives a good result. Yeah,
And would
as
you
far
say
as
that,
I
like optical biometer is something which we are all somehow using?
using, yes.
And would it be wise to also take an immersion in such patients, or maybe two consecutive readings would also help us save the dark day the next day?
An average of multiple readings will indeed help. It will help us with, filtering out any outliers,
That's correct.
which is, in one sitting, it's not possible. So, yes.
Perfect. Himanshu sir, can you give us one pre-operative red flag that surgeons most often ignore in such eyes?
Be very sure that the pressures are going to be very high. The moment
Uh,
you put any viscoelastic, don't ever use methyl cellulose or something, use dispersive if at all. And I'm a
Excellent.
femto guy, so these are absolute indication when the shallow AC is there to get a good rexis. The whole surgical success depends on a good rexis.
Excellent.
And one of the things that I would do if it's a very 10 size small eye is definitely a small vitrectomy early rather than a sclerotomy.
Okay.
I debulk the vitreous.
Right. Dr. Abhijit, should these extreme axial lengths need a separate consent? Do you say that? Can we make a
Uh, yes, they should have a separate consent, especially with relation to having refractive surprises. And maybe you should also confirm on multiple formulas. I prefer the true axial length formulae which Barrett gives on the Argus, and I cross confirm it with the ESCRS IOL calculator. And we have a way of comparing all the formulas, and then we average out on a mean for the IOL power.
perfect? Anything
So,
else Rajan sir would like to add?
I'd like to ask all the panelists that what is their choice of IOL? Suppose patient has a power of plus 50 or plus 45. which is not available. So two lenses in a piggyback way or a custom made lenses. What is your like preference? Yes, Himanshu sir. Rajendra sir. Yeah.
The space is already less for a piggyback, I would say. Given a choice, almost certainly, uh, absolutely, we have the pleasure in this country to make to order. There is no hurry worry with a standby plan and go on a myopic side. You'll always be a hypermetropic surprise, so you rather go on a myopic side. That's for sure.
What is the maximum power which you have implanted till now? Your
42.
maximum score.
42 that I've
42.
done.
Yeah. So I had a case which had power of plus 54 with the eyes, and yeah, we got it made, and it was, and they always send you in two lenses. So, and they make the optic size smaller. So optic size is 5 mm as compared to 6 mm, so that it becomes easier to implant and it goes smoothly.
But surely your microphone, if you can just keep it a little closer to you, your you're a little slow. Are you on a Bluetooth? Are you on a Bluetooth?
I think
Yeah.
If you could get off with it, because there is disturbance.
Okay. Can you hear
just
it now, sir?
one more quick one. Meanwhile, Arshul sets his mic. Again, to all the panelists, what is your immediate intraoperative cue that a uveal effusion is developing?
I would do a sclerotomy.
Okay.
I just operated yesterday only. A very high hyperopic patient. The biggest problem what you come across during the surgery is the vitreous upthrust. And these eyes generally have a very thick lens. So another important point you need to consider before we look at the lens thickness. The eyeball size may be small, but the thickness of the lens or the size of the lens is generally very big. And I was really surprised to see the size of the lens, like it was so thick and big, and there was a continuous vitreous upthrust. So the best thing is, like most of these patients, you keep them on pre-operative pressure lowering medicine, like you start Dimox is the best thing to do pre-operative, at least 2 to 3 days. And then intraoperatively, IV mannitol should be given in most of these cases so that you have a profitable surgery during the lensing and the IM implantation.
On a note like this, Saurabh, how would anybody diagnose an early uveal effusion? That is an important question. How would you know that? You know, it's a very nice autopsy diagnosis, but on table, how do you kind of, the whole crux is diagnosing it early. How does one do that? What do you look for?
So the one thing that I look for and I have faced is the patient starts complaining of pain.
Achha.
And it's an excruciating pain when the effusion starts. And as Dr. Rajendra Prasad also said, you would get that upthrust which would start increasing, and your AC would be shallowing with a hard eye. So these are the few indications that you would look for, pointers to look for either a suprachoroidal or a effusion.
Perfect. So I think we can move on to the next speaker. Komal, can you please do
Yes,
the
sir.
introduction? Yeah.
Um, I'm pleased to invite Dr. Bhupesh sir. He's a senior consultant of cataract, cornea, and refractive surgery at Bharti Eye Hospital, New Delhi. And his areas of interest are corneal transplant and challenging cataract surgeries. He's published many scientific articles in peer-reviewed journals and presented instruction courses in AIOC, APAO, ASCR, and ESCRS. He has also been awarded APO Achievement Award and International Hero Awards and has multiple Best Papers and Best Video Awards from AIOS, AIRC, and APO. Welcome, sir. Sir will be speaking about problems in the long eyes. Over to you, sir.
Thank you, Dr. Kumal, for the introduction. So I have some issues with my camera of the computer. So I'll be joining with the mobile also. Just give me a second.
I need to share the video, please. Is it visible now?
Yes.
Yes, yes. Clear.
So, good afternoon, everyone. Thank you, Dr. Harshul, for inviting me in this wonderful session on cataract surgery in extreme eyes. And I'll be speaking on problems in long eyes. So, Dr. Komal nicely summarized most of the point faced in cases of short eyes. So, I'll be discussing of problems in long eyes. So, as we all agree that problems in long eyes more common than problems in short eyes because cases of long eyes are more common in our OT setups. So, let's start discussing these problems. Where's the next? It's not moving. My slide is not moving either. Slide control. That's coming. Just a second. Okay. So the problem of cataract surgery in high myopes or long axial length eyes starts with the preoperative evaluation because the first issue is the retinal pathology. As we all know that high myope patients are mostly associated with some or other kind of retinal pathology. Maybe it's a peripheral degenerations, holes, or many a times posterior staphyloma in extreme cases, and sometimes hidden maculopathy, retinoschisis. All these problems are associated with high myopes. So it is a must to evaluate retina properly. It's always better to get these evaluation done by a retina surgeon so that you don't miss anything. That is the first and most important thing. The problem comes when cataract is more and retina seems weak because in those cases the evaluation is not very great. So OCT is a good tool. So OCT should be done in all cases of high myopes so that you don't miss any maculopathology. And if you have white field imaging system, then you can look for the lattice degeneration or holes and tears, and you can document and explain to the patient. The problem comes if there's undetected retinal pathology, it increases the risk of retinal detachment because in high myopes, detachment is more common. The incidence is higher than in case of normal axial length patients. So, detailed peripheral retinal examination is a must. We should consult retina consultation in all cases. Prophylactic laser, if needed, should be done before surgery. And as I discussed, OCT macula is a must. So, coming to the second problem, is assessment of zonular status. Because high myo patients have very big size bag, zonal laxicities are very common. So you have to assess for any kind of phacodonosis in these cases. So always look for the phacodonosis, especially in case of this pseudo exfoliation trauma. And otherwise also zonal assessment should be done, complete dilatation checkup should be done. Never plan your surgery without dilatation or mid dilatation. Look for these things. And if you miss these findings, then intraoperatively there will be a problem and you have to manage zonal dialysis cases intraoperatively. So in preoperative, look for phacodonosis, assess lens centration, ask about prior trauma history, and plan for capsular support device in advance. So it has to be there in the operation theater if you're operating a high myope case. Coming to the power calculation, Dr. Komal has nicely summarized different formulas. So for longer eyes, right now the standard of care is a Barrett Universal 2. In most of these cases, the outcome is excellent with Barrett Universal 2, although there are different formulas like Kane, Haggis, HVO2. So these formulas are also available, but in my experience, these are not very popular formulas because Barrett Universal 2 is very simple to use and results are good. So my suggestion is to go for Barrett formulas, and definitely we should avoid the standard formula that we use in routine practices like SRKT, for Q holiday. These are not reliable at all in high myop cases. And if you're not sure that you're going to get a good result with one formula, you can definitely go for different formulas, see what kind of values they are given for oil power calculation, and go for the on the myop side, because these patients many a times land up in hyperopic side. It's always target myopia. One important thing that I want to tell is that excellence is a very important factor in determining of IOL power. So if there is an error of 1 millimeter, you are going to land up of effective error of 2.88 diopter post-operatively. So one of the crucial factor is to know the correct axial length. In myop patients, the staphyloma is another problem. If there is a staphyloma, there's a fold in the retina in that area. So many times you get a false reading. So it's better to have a immersion method, contact method, non-contact method, and you can compare what kind of reading you are getting, and always go on the myopic side. So Barrett 2, so I'm not going into detail. We all know that this is a thick lens theoretical formula, and it is based and it's uses biometric variables rather than axial length alone. So the accuracy of Barrett is more in patients with axial length of more than 26 millimeter. Barrett works very well. And whereas Haggis is also very popular formula, this is used in cases with high myop of more than 26 to 27 millimeter axial length, and they have some revision with optimized constant. So if you use Haggis, use these constant and get a better results. Works very well with the very deep anterior chamber cases. So this is a chart showing in which cases you go for the Barrett and in which cases you should go for the Haggis or Holiday 1. And the target is in all the formulas, the target is always myopia. Some are 0.5 and some are 1 to 2 diopters, like in Haggis. So always target myopia in all cases of high myop patients. So coming to the intraoperative issues with the in a high myop patients. So starting with the phaco all these myop patients have a deep anterior chamber and long axial length. Along with that, the scleral rigidity is also very low, and it reduces the vitreous support. So eye behaves as a large compliant chamber. And because of these issues, when you start your phaco inside the eye, there is sudden deepening of the anterior chamber. So if you're operating in topical phaco, then patient may experience severe pain in these cases. And because of the high myopia, the uh, blocking or giving the peribulbar retrobulbar blocks is not very much advisable in these cases. So one thing that works very well in these patients is a uh, bottle height gradient that is there in Centurion machine. So you can slowly increase the gradient so that patient can adjust patient's iris diaphragm, and its pain threshold easily adjusted with the Centurion, and the pain is less in these patients. So another problem is because of very deep chamber, the nuclear fallibility is very poor, and surge is very high. Posterior capsule folding or trampoline is very common in these cases, and risk of PCR is also very common because of sudden collapse or sudden deepening of the chamber. So because of that, your incision should be very tight. It should be watertight. It should not come out in a jerk, and you should start phacoemulsification or flow when you enter the antechamber. Don't start outside, because uh, when you start the sudden irrigation, sometimes the iris gets stuck on the nucleus, and there is a problem in the surgery. So always go inside, lift the iris a little bit, and then start irrigation. So by this technique, you can handle these cases very well. Lower infusion pressure should be there to avoid pain or certain too much deepening of the antechamber. Moderate vacuum rather than the peak vacuum should operate on a moderate vacuum. Reduce aspiration flow rate to make a chamber quite stable, because chances of iris fluttering is very high in these patients. Keep phaco tip central and anterior, because iris keeps on moving. You can catch iris in between. Smooth foot pedal transition. You should not come to position 0 in between the surgery, because there can be a complication with that. Low flow, low vacuum during the surgery. So another problem is deep antechamber. The problem with the deep antechamber post-occlusion surge and poor fallibility of nuclear fragments interoperably. So reduced bodal height, as I discussed in the previous slide, low respiration rate, moderate vacuum rather than the high vacuum. So next is a capsulorhexis in these high myope or long eyes. The chances of rhexis extension is very high in high myope patients. It can run peripherally, so large capsular bag exaggerate pressure, so due to which the rhexis extension is quite common. So it's better to avoid to use trypan blue because sometimes the eyes are so deep that focusing on the lens is also become a challenge. I will show one case in which it was so difficult to focus on the anti-lens capsule also. So better to use stains, create a slightly smaller rhexis initially, and then you can extend that. Rewrite the tear inward frequently if it happens, and aim for moderate size 5 millimeter to 5.25 millimeter, not very large rhexis in these cases. If rhexis starts to run outside, you can stop immediately, inject viscoelastic to flatten the capsule, and then regress closer to the tear edge and pull it inwards. So if you encounter zonular weakness or capsular instability during the surgery, you will see that there is a lens wobbling inside the eye, it's difficult to rotate the nucleus, and bag become unstable. So intraoperatively, we should minimize nucleus rotation in case of zonular dialysis. Do not rotate too much. Perform gentle or multi-quadrant hydro. Do not aim for single fluid wave in zonular weak cases, and go for a small amount of hydro in different quadrant and insert CTR if necessary. And there are multiple studies which shows that if the myopia is very high, it's always better to go for CTR because it stabilizes the bag. If there is no dialysis also, you can use CTR and get a stable bag in these patients. So during cortical cleanup, strip cortical tangentially, not radially, and reduce aspiration parameters because if you use a very high parameters, patient may face pain. So the role of CTR in these cases is that CTR redistributes zonular forces circumferentially and stabilizes the capsule bag both intra and post-operatively. The next is a posterior capsule mobility and PCR risk in these patients. So the chances of PCR are high in these patients because the capsule is thin, mobile posterior capsule, and sudden anterior movement may land up in PCR. So avoids deep sculpting in high myopes, maintain phaco tip above the iris plane, use low flow, low vacuum during irrigation aspiration, never allow the chamber to shallow suddenly. So these things always works in normal phacos also, but in high myopes, importance of these steps becomes more. So if PCR occurs, you can stop phaco immediately, inject viscoelastic before withdrawing the instruments because chamber is so deep. If you withdraw suddenly, the entire vitreous will come in the AC only. So perform control antivitrectomy if needed. And next is a reverse pupil block. This is very common in high myope patients. The iris bows backward and sudden deepening of anterior chamber occurs. So intraoperatively, we should periodically lift iris with a cannula to equalize pressure, avoid excessive infusion pressure, and maintain moderate pupil dilatation. If there is a persistent reverse pupil block, use a dispersive viscoelastic to stabilize iris configuration. And this helps in balancing anterior and posterior chamber pressure and restores physiological iris position. So this is one thing to be aware in these cases. Next is the vitreous prolapse risk. Chances are very high. We should avoid overhydration during hydrodissection. As I discussed, always maintain a stable chamber. Perform antivitrectomy if vitreous comes in the antechamber. Low vacuum, and we should convert to sulcus or optic capture IOL if needed. The problem with the IOL in high myopes is IOL decentration and rotational stability because of the very large bag. And the problem of PCO is also very high because there is a very less contact of IOL with the capsule. So if there is a large bag, as I discussed, go for CTR. Whether there is a dialysis or not, go for the CTR in very large bag. If you see that your lens is not getting stable and it is moving, it's always a better idea to use CTR. Always confirm final centration before viscoelastic removal, and avoid sudden pressure fluctuations, minimize vitreous traction, and gentle wound construction and closure is a must. So in post-operative, the main problem with high myope is a refractive surprise because of the IL power calculation error. So the aim is go for the multiple calculation method, use multiple formulas, always target the myopia so that you should not land up in hyperopia. Risk of RD in myope is there, as I discussed in the first slide only. Proper evaluation in preoperatively, and if there is a post-op RD, we can tell patients in preoperative that you have a high risk of detachment in postoperatively. So regular retina evaluation in postoperative period is a must. So PCO and ILD centration already discussed here. So I'll show one or two short videos. So as a cornea surgeon, we always get these patients. The problem arises when the pathology is very long eyes along with the cornea problem. Like this is a case of keratoglobus. So in keratoglobus, the cornea is so steep, dense, intumescent cataract. The limbus is bad. You can see here LSCD is there. The K1, K2 is 49 and 63, almost 14 diopters of astigmatism. Axial length is 28.3, AC depth of 6 millimeter, and IL power was minus 10 diopter. So you can see the extreme long eye and very steep cornea. So in such cases, especially in keratoglobus, go for the sclerosing because the cornea is very brittle. You can see the intumescent cataract, making the job even more difficult. So it was not possible to focus on the capsule because it was so deep. So I started the thing and aspirated the loose fluid here, and then started the rexes. It was standing all around. Luckily, I got the rexes done nicely. And in this case, you can see the focus is not very clear because either you can focus on the wound or you can focus on the nucleus. So you have to compromise somehow and manage such cases. You can see the iris movement here, certain fluttering of iris. So go step by step. Better to initially divide the nucleus in two parts because direct chop becomes difficult in such cases. And always take it out above the iris and then finish this case. So this is a three-piece lens because with minus 10, you don't get any other lens. So three-piece lens was put in this case and patient did fairly well. Another problem of high myopia occurs when you get a cataract in post-RK along with high myopia. So post-RK itself is a challenging situation. High myopia is a challenging situation. So operating in those cases is a difficult task. IL power calculation is again Barrett, works very, very well. Barrett's 2K with RK works very well, give excellent results. So always use ASCRS calculator in Barrett 2K formula. Mostly you don't get the history, so you have to use partial history or no history formula and get a good results. Always target myopia. And in RK cases, always target at least 1 or 1.5 diopters myopia because RK is known to give you hyperopia in postoperative period. So go for high myo in postoperatively. Challenges with RK is mainly is the incision challenge. With 12 or 16 incision, you get a proper space to operate, but with the 32 or 28 incisions, it's very difficult to get a clear zone of incision. Although you still try to get a clear zone, or you can move a little bit scleral to avoid any opening of these incisions. Low parameter should be used because these corneas are very weak. Chances of wound dehiscence is always there or opening of these incisions. So I'll show just this is the last slide, just a small video of post RK. You can see what goes wrong here. So we did a femto RK in this case, opening the incisions, and you can see the incision is cutting one of the RK cut, and as soon as I entered, you can see the cornea is tearing up. So this is a major problem with RK cases. All the cataract was very soft, so it didn't extend too much. I managed the case somehow, and the technique of managing such cases, you put the lens, and after that, you can suture these openings. And I put two 10-0 nylon sutures, and patient did well. It closes nicely. So So we should avoid such complication in post-arcane high myope eyes. So thank you so much.
Thank you, sir, for the engaging presentation and clear and concise overview of problems in myopic eyes. Sir, I would like to know what is one mistake that surgeons commonly make while operating in a long eye, in a myopic eye.
So,
What do you
so
think?
in myopic eyes, the main problem is if you start with the preoperative, first is the IL-power calculation. You have to go on always on the
Rupesh,
myopic side.
can you unshare your presentations for so that
Yeah,
we
yeah,
can?
just a second.
Yeah, perfect.
Yeah. So the with the myopia, the problem is the if you again the same thing preoperative because many times the list is so long you don't focus which is hyperopic patient, which is myopic, which is normal hemetropic patient, and you put always the target emetropia. So always look for the axial length, tell your optometrist, train your optometrist that if axial length is very high, more than 24, 25, go for myopia side, and if it is extremely advanced long eyes, then you have to customize it more around. Maybe you can go for -1 also because the entire life patient is myopic. So if you make that patient e-metro, then also patient is not very happy because patient is used to see near things very clearly. So, and with the staphyloma, all these pathologies, going for trifocals and all these case things in extreme, I should not be advisable, in my opinion. Go for the monofocal or maximum monofocal plus lenses. Target at least zero point 0.5 to 1 diopter myopia, so that with monofocal plus you will get around -2 easily. -1 with the lens, -1 with the monofocal plus, and patient can see near vision very clearly. So one thing is that intraoperatively, one thing that I found very useful technique is always start your irrigation very slow intraoperatively when you start the surgery because all these patients start complaining as soon as you put irrigation pedal on. They wince, they move their head on the other side, Phaco probe comes out many times. So use the, if you have the higher end machines, use this bottle height concept. This is very, so I put 3 seconds. It takes 3 seconds to go for the, fill the entire chamber. So patients become very comfortable with the 3 second parameter. So you can use that or you can start the irrigation or use the low parameter. So these two things are very important in high myopes.
Thank you, sir. Uh, for the expert panelist, sometimes when we operate in myopic eyes, we see that the pupil snaps and the size becomes it constricts basically. And literature or whenever I was reading, so they say that if you lift up the pupil iris with your dialer, this the patient gets relief, the pupil's dilation improves. What do you think, like, what can be done in such cases, and how effective is this maneuver?
See, actually, this is one of the problems we come across when we are dealing with these high myopes, the pupillary snap sign. And the best thing to do is like whenever you are injecting the viscoelastic, no, just inject it underneath the iris also. So don't inject too much of viscoelastic in the anterior chamber over the iris. You inject on behind as well as on the anterior surface of the iris, equal amount of the viscoelastic, so that you maintain the posterior uh, chamber and the anterior chamber equality of the depth, because they have a very deep chamber. If you keep on injecting, you'll find that the whole lot of syringe of the viscoelastic will go inside. So make sure that you are not injecting too much of viscoelastic. So that is, I think, one of the point. And then, as you told, like once you start the go with the Phaco probe inside and the irrigation has started, then that time you need to lift with your second instrument. Just try to lift the iris up so that the slit goes behind also. So you'll not get this kind of problem then.
Thank you. Also, what factors predispose to late IOL dislocations? within the bag IOL dislocations in very high myopes or later stages? What should we look for preoperatively to prevent such cases?
Uh,
I had an interesting case. I had a very high myopia who had a toricity of 1.5 in one eye and around 2.25 in the other eye. And he was really keen to be spectacle free. And we advised him that maybe not a multifocal, but we can order for a customized toric IOL. So this was in the era when IOCare never used to make customized lenses. So we got that done. We got around 6 weeks and we implanted the IOL. Patient was 6'6" the first day. And after a week, he came down that I'm not seeing well. So he was at 660 and the IOL had rotated around exactly around 90 degrees. So in high myopes with a big bag and a thick lens, the diameter, the bag diameter is very big. So plate haptic IOLs or IOLs which are around 11 or lesser than that, these are to be avoided. So if you are going to be implanting those kind of IOLs, then you need to be careful about what is your plan B, plan C, plan D. Incidentally, when you're rotating re-rotating the toric IOLs in the early post-op period, the bag is still the same size. It has not contracted. So the ideal time for even rotating and getting these IOLs centered would be around 3 to 4 weeks, not before that. So that is something that you'll need to keep in mind when you're operating on very high myopes.
Should we move on to the next presentation?
Yeah, Komal, just a minute.
Yeah.
I think Dr. Bhupesh has covered this topic very nicely, and he has shown us that how we should prevent LIDRS and all those things. So I'll just like to quickly share small clip for all the attendees who are here, so that they can understand well that how to take care of this by this maneuver which we all were discussing, that whenever we have LIDRS, how to. Is my screen visible here?
Yes,
Yeah.
sir.
yes.
So this is a case which is high myope, and see, just after I put my, so as soon as I put my Phaco probe, keep an eye here, iris goes back. So that is typical LIDRS. That's what there is a reverse pupillary block there. So it's very simple. You just go ahead, and the chopper which is there handy, or a Kuglins hook is there. So I just flatten my, keep it horizontal chopper so that I don't damage the anterior capsule, and just try to tent the iris up. So the moment you tent the iris up, it gets relieved and the entire nucleus it comes up, and then you can do Phaco. So this is what typical LIDRS, and in between also many a times you need to repeat the maneuver, because as we start doing Phaco again, it tends to build up. So whenever you see that your nucleus is going down backwards and it's the reverse pupillary block, you go and release it. Just see, the moment I put my irrigation cannula there, again everything goes back. So you go with aspiration cannula, you first tend to lift the iris up so that you have everything in place and it becomes easier. So this was just a small maneuver which Upesh mentioned. I thought let's show it for all the attendees.
That was a very
Yeah,
nice
let's.
demonstration, Arjun.
Yeah. And another thing is, as Dr. Bhupesh mentioned, that the eyes which, like post-RK eyes, we should always be careful. They have higher axial length than patients of keratoconus, keratoglobus, where visibility is poor and axial length is also maybe higher, or the cases which had undergone DELC. In those cases also, so there was one case who had undergone a dissect. So there was a rim which was there, and patient had high myopia also. So the moment I go in, the entire everything goes back, and because of that rim of dissect, the visibility was so poor. So you need to be careful of these cases also. And one question to expert panel before we move ahead, that there are cases which have high myopia and who have low IOL power with toric lenses. We know that there is a high propensity for them to rotate. So do they routinely put CTR ring in those high myopes with the toric, Dr. Imanshu?
I don't, but I have a colleague of mine who uses it routinely from long number of years, and he's convinced. I'm not very convinced because if there is a subluxation, that CTR can be a disastrous for me. So only and only if I find that the bag is sloppy or something more, then I would use a CTR in those cases.
So I use the CTR in case I'm using the plate haptic lenses, which are, and in that case, what you can do is with the hydro, whenever you're doing the hydro, just go in the chamber and forcefully inject so that the eddy is circumferential. Many a times you will find the lens rotating. In that case, you
Yeah,
can supplement
yeah.
it with one more CTR so that it doesn't move at all.
DTR, I won't put on each and every case, but yes, definitely, if you find fluttering posterior capsule during the surgery, like you see there are a lot of movement of the posterior capsule, the whole bag is moving up and back. These are the cases I think then we need to put the CTR.
Okay. I think let's move ahead, Komal.
Yes, sir. So our next speaker is Bharti. Just Ma'am has completed her undergraduation from Bangalore Medical College and post-graduation from Minto Regional Institute of Ophthalmology. She is trained in vitro retina in the Retina Institute of Karnataka and currently working in the retina and uvea department, and is also a proficient cataract surgeon at Megar Eye Care Center. She has participated in various state, national, and international meets in American Society of Cataract and Refractive Surgery as an instructor in instruction courses, and has presented many scientific papers and videos in European Society of Cataract and Refractive Surgeons. She also was the chief instructor for instruction course of APO and AIOS conferences, and she has been an invited faculty in various state and national conferences. Welcome, ma'am. Looking forward to share your insights.
Am I audible?
Yes, ma'am.
Is my screen visible?
Not yet.
Yes,
No, ma'am, no.
One second. No one.
There is a green icon which says share, right?
Yeah, I have shared it, but yeah.
Yeah, it's come now.
Yes, ma'am.
It's visible, right?
yes.
Yes,
Yes, ma'am.
if you can just click the play button on top, doctor,
Okay,
which is
okay.
play.
Yeah. See, actually, in long eyes, we always talk about the difficulty in the biometry and calculations. And most often than not, we have these hyperopic surprises, which we really don't want in myopic patients who have enjoyed good vision for a very long duration of time. So some of the formulas which work best for all these long eyes are usually the Barrett's Universal 2 And recently we have this ECRS calculator, which has one more. Yeah. Incorporated this online platform of calculation. This ECRS calculator has the Barrett's, EVO, Hill RBF, and Kane. And in extreme outliers, the Kane formula is supposed to be the best. But since all of us are comfortable with Barrett's Universal 2, and it is the go-to formula for most of the cataract surgeons here. So we usually in our setup too, we use the universal Barrett's formula for most of our myopic eye calculations. Generally, the target is to get a minus target, actually in the range of half a diopter or almost -1 diopter, to retain the near vision the patient is been enjoying. So any hyperopic shift the patient would not tolerate. So we have to be watchful about the biometry which we are doing for these patients. This is about the fundamentals which I wanted to talk about biometry. Is my screen visible now?
Yes, doctor. Can you just make it in full screen, please? Yes. Now it is visible.
Yeah.
Yes, ma'am.
So I'll be sharing two short videos on short eye and long eye. The first one is on longer eye. This is a patient who is a 56-year-old lady. She has a grade 2 nucleus with myopia, well-dilated pupil, and an IOL power of 1 diopter. Generally, when we see these patients who have these long eyes, the pupillary dilatation is almost limbus to limbus. This is a challenge for one critical step in the cataract surgery or phacoemulsification. Getting the size of the rexis becomes critical. So this is the biometry evaluation. Some red flags are already raised by the ultrasound scan or biometry scan. The red flags are shown in asterisks and certain times exclamatory marks. And here we see the axial length is 30.7. Lens thickness is 4.31 and the IOL required is +1. We are aiming at -0.33. The challenges here again is sizing of the rexis, avoiding the sudden deepening or shallowing of the AG, anterior chamber, the prevention of the lens iris diaphragm retropulsion syndrome, and centering the IOL. These are the critical challenges. First thing here, we make the side ports. I use the trypan blue strain to get the rexis because I want to see the anterior capsule clearly. Certain times I would advise using a template like a corneal rexis marker to get the right size of the rexis because we want 5.5 millimeter rexis, nothing larger than that. So to get the accurate rexis size, we can use a corneal marker. The steepness or flatness of the parallax effect of the cornea can sometimes be misleading in the rexis size. So we need to get the accurate rexis size. The main wound is made. A gentle hydrodissection because we don't want any fluid to be entrapped underneath the iris. Here I am using a bottle height of about 55 to 60 centimeters. I don't want deepening or sudden deepening or shallowing. This is in with intention to prevent the retropulsion syndrome. Getting a direct chop with a 20% longitudinal burst. And here the grade of the nucleus is grade 2 NS. So almost all the quadrants are chopped. And in the safe pupillary central area, the nucleus fragments are removed. So now all the fragments are easily emulsified. Almost all the patients of myopia tend to have nuclear cirrhosis, sclerotic component more often than not. And so the discussion was almost all about the retropulsion syndrome and how to prevent it. I have seen certain cases of long eye patients who don't have this retropulsion or this LIDRS happening in almost all cases. I think it depends on the scleral rigidity also. So whenever the scleral rigidity is there, the LIDRS does not happen. When there is very low scleral rigidity, when the bag and the anterior chamber can take up lot of viscoelastic or fluid, then the retropulsion happens. So tangential stripping of the cortex is done. Flushing of the small epithelial fibers on the PC. And I invariably use cohesive viscoelastic to implant my IOL inside the bag. This is a 3-piece acris of IOL. Almost all the viscoelastic from behind the IOL is removed and hydration is done. So the sizing of the rexis seems perfect because I think the 1 mm overlap was achieved. Coming to this short eye patient, let me go back a frame a little bit, okay? So this is a patient who has an axial length of 18.5 millimeters and her lens thickness is 4.44. She requires an IOL power of around 40 diopters. And both eyes are similar and our AC depth is 2.59. So in this patient, the challenges are again having a shallow anterior chamber, difficulty in maneuverability, risk of the iris prolapse, radial rexis, and risk of PC tear. So again, the standard trypan blue staining and getting the rexis. Construction of the main wound is a little critical here. Having a little intracorneal length which is longer helps to prevent the iris prolapse from happening. So the rexis is little smaller than what I anticipated to do. Getting a hydrodissection here. Almost always when you're doing in these eyes, which are short eyes, which cannot accommodate lot of viscoelastic or fluid, over inflation of the anterior chamber or over hydrodissection should be avoided. This is a very soft cataract. There is not much of a nuclear component. As you can see, there is a little bit of struggle happening here. And using 10% longitudinal burst mode, in the quadrant removal mode, I remove almost all the entire complex of the nucleus, epinucleus, and a little bit of cortex. So the usual steps of cortical wash. So as usual, I'm using a cohesive OVD to form the bag to implant a single piece acris of 40 diopter IOL. So removing the viscoelastic is critical from behind the lens, and a bit of enlargement of the rexis was also finally done, and this is the end. So yeah. Can I stop sharing? Hello?
Sure.
Yes, ma'am. Thank you for the beautiful surgical videos. Uh, one question that is coming. that I wanted to know what is your ideal rexus size in when operating in small eyes? What do you aim for?
Invariably, in all the patients where you are doing cataract surgery, 5.5 millimeters is the standard size of the rexis. This is because the IOL optic size is 6 millimeters. You want a 1 millimeter overlap of the optic. So whether it is a small eye or a big eye, or a long myopic eye, you would want a 5.5 millimeter rexis. But it becomes more critical in eyes like myopic eyes because you don't want the IOL to decenter.
Yeah. Okay. Another thing was you mentioned a longer corneal incision. Anything other than that in corneal wound construction that you would like to share?
Little bit of anterior length of the wound should be maintained to prevent the iris prolapse. Overinflating, injecting excessive of viscoelastic, these things have to be avoided. Even very aggressive hydro procedures can push the iris below the iris up and cause prolapse.
Yeah. Yes. Thank you.
Dr. Magur, the second case had a very, very soft cataract, and
Yes, sir.
where you could remove the whole complex with the aspiration mode only, like you didn't use any filter. So in many of these cases where you have a very short eyes and where you expect very shallow chamber and all these factors, so I think the best way is, like, if you think that the cataract is very soft, uh, don't make the main tunnel, like the main node, the split incision. Just make it partial halfway, and if you are able to remove the IA mode only, the whole complex, then we don't need to give that large incision so that you don't have the iris prolapse, and all these factors will be prevented. I think
This lady,
this is like
yeah,
it.
sir. Yeah, sir, I agree with you. This lady had a small endonucleus also. The first attempt was to get a chop, and that did not happen. You have to change over your tactics and move to the next tactic of removing it safely. And the second important thing is, unlike the myopic cases, you need to maintain the good balance of infusion in the anterior chamber. So my bottle height in these cases were 90 centimeters.
Right.
Dr. Abhijit, what is your strategy to make sure that you have a perfect size of rexes in high myopic eyes? Because in those cases, yeah, one always tend to make a bigger rexes, because the antechamber is
Relative size.
larger. Yes.
So what I do is I have all my patients on the Varion, and on the Varion we aim at a 5.3, not even a 5.5. So if you are aiming at 5.3, invariably you would end up with a 5.5 with a high myope. And the other trick is, in high myopes, you should not overfill the chamber. If you're overfilling the chamber, sometimes that can be a problem, and that causes a problem. So it doesn't give you the exact size of the rectum.
And
That is something that you keep in mind.
another important point with the high myopic is your capsule is very elastic. These eyes have a very elastic capsule, and it's stretched up. So because of the big bag, stretched capsule. So don't aim for the larger capsule or axis in these cases. Otherwise, it will go too large. If you aim for 5, then you'll get 5.5. This is what happens with these high myopic eyes, and especially if the patient is younger patient, say in 20s or 30s, then the capsule elasticity is still higher. So don't aim for the 6 or 5.5. You'll land up with the 6.5. It is not advisable in these eyes because you don't want too large capsule or axis.
Yeah,
Dr.
because
Komal, one more advantage. Dr.
Yeah.
Komal, one more advantage of having a
Yes, sir.
5.5 or lesser rexus is, in case you
Yeah.
have a PCR and you have a good capsular support, but not a PC capsule,
That's right.
and put the IOL in the bag and do an anterior optic capture as well.
Yes, sir.
So that is the time you can actually be saved from a lot of problems.
Okay.
I think it's
Yeah,
it's,
and
it's
Dr.
always
Komal, I
better.
think for a beginner, no, whoever is wanting to do a perfect 5.5 millimeter axis, you have external corneal marker, which you can use
Yes.
try blue and mark it in the center of the Purkinje images. Keep the center as the Purkinje images and mark it on the external cornea. Till about you make the rexis, it will be there so that you can get the rexis size correctly.
Okay.
You
These
need to put in the
extreme,
earphone. Can't hear you. We
can't
can't
Yeah,
hear
hear
you
me?
properly.
yeah. I've seen some people using that marker actually on the cornea. But you see,
Yes, sir.
because the magnification factor at the iris level and on the corneal surface is different. You mark on the cornea, you will
True.
not get the same size on the capsule.
True.
Again, you will have to
True.
manipulate it. So I think the best
Yes.
way is like you do your axis, keep in your mind like you're not making too large and make it within 6 millimeter size of capsular axis.
Right.
Am I audible now?
Yes.
Yes, sir. Yes, sir.
Yeah. So what I was saying, as Dr. Bharti showed, it's very crucial to have a good overlap of capsular axis, especially in extreme of hyperopia and these cases, because effective lens position, if it changes, if we don't have good overlap, will have a very bad effect on the effective power of the IOL. So I always tend to err on the side of making a smaller axis, unless and until it's a very hard cataract that you can't take it out through a smaller axis, means smaller. So because in the end you can always enlarge it to the desired size, but if you have a bigger axis, and especially in hyperopic eyes, in smaller eyes, there is a lot of upthrust, as Dr. Bhati showed. So the IOL tends to move upward, out of the capsular bag. So it's very important to have a smaller axis in the beginning, and then you can always enlarge and trim it to the perfect size at the end of the
Also an
case.
option.
Okay. I think let's move ahead, Saurabh.
Yes, sir. So now I would like to invite Dr. Rajin Prasad, sir. Of course, he doesn't need any introduction, and I'll just briefly introduce sir. So he is an alumni of RP Center Ames. He has many innovations toward under his belt. I hope my slide is visible, right?
No, it's not visible.
It isn't.
So the slide is.
No, slide is not visible.
I have shared my screen. Anyways, uh, I won't take much long. So he has many innovations under his belt, especially the terminal chop technique, the sewing needle microcapsulotomy. He known the Terminator, of course, in the stream of ophthalmology, the wedge tool. He has that high dissect for the PPC and the T soft for the soft cataracts, which he was just mentioning. He's also been awarded the National Innovator Award in 2018 by the National Constitution IMA on the August 4th. He's also been awarded with the International Hero AIS Award. He has the best video ASCRS consecutive times, a lot of times. And he has the best paper ASCRS in 22 and then AIOC 2017 and 21 and IRSI. And he has many publications under his belt. So over to you, sir.
Okay. Thank you very much. Thank you for the nice introduction. And I'll just share my slide. Okay. I hope my slide is visible now.
Yes, sir. And just a moment, sir. Sir would be speaking on Phaco in extremely long eyes.
Okay.
Please go ahead, sir.
So today, actually, as my previous speakers have already spoken a lot about the phaco in extremely long eyes. So, but still, I'm going to discuss. This is one of the most challenging subsets in refractive cataract surgery in today's time because every patient who comes to your clinic, they are looking for the complete freedom from the glasses. But we know that these long eyes in the era where the patient's demand is very high, it becomes a difficult job to give them the correct results.
Can you do a full screen, please?
Okay. It's all right now? Yeah.
Yeah.
Okay. So why it is so difficult, the phacoemulsification in long eyes? Because we have a structurally oversized eyeball. And as we have discussed, anatomically very unstable eyes. Surgically, these structures are very fragile. And over that, we have a biometric hurdles because you do not get the correct IOL power calculation in these cases. And generally, you land up with the refractive surprises and high intra as well as post-op risks are there with these extremely long eyes. So first, I'll just show you a small video of a patient, a young patient of 28 years old, of very extremely long eye. You can see 35.81 millimeter was the axial length of this patient, and refractive error was minus 30.5 diopter. So you can see this is the eye, and patient had a very minimal characters changes, not much, but patient was more interested in getting rid of glasses, that minus 30 diopter of glasses. So we started phaco emulsification for this case. As you can see, like I'm injecting very minimal kind of viscoelastic. Don't pressurize, as I said earlier, minimal uh, injection. This was the LRI done for this patient because I didn't want to go in for the toric IOL because instability of the eye. The toric IOLs are always avoided in these cases because of the high capsular bag size. Your incisions have to be triplanar so that you have a closed chamber surgery. As I said, the capsule is very elastic in these cases, but as you can see here, I'm just trying to aim for a 5 millimeter of capsular axis. This is, I normally use capsular axis forceps only, and this becomes a much better hold on the sizing of the axis as you wish to. So this was a around 5.25 millimeter size of capsular axis. Your dissection is again very important step in these cases. You need to completely separate the cortical matter from the capsular bag because this will make your surgical steps much easier a little later. And if you do a complete dissection of the cortex from the capsular bag. Now you can see there isn't much of nuclear material in this particular case. I'm doing the hydrodelineation also. And then I just, as I said, I didn't go through the main wound. I just went through the IA mode for this patient and trying to aspirate the cortical material as well as the complete cortical and nuclear complex with the help of the irrigation and aspiration mode. So I could remove it completely and see this finally the whole material is aspirated. Do a good anterior as well as posterior capsular polishing in these cases because you do not want to left with the capsular phimosis because this is one of the more very important complication we see with these high myopes is the capsular phimosis. So if you do a good capsular polishing, you will reduce the incidence of capsular phimosis. And then IOL, as you can see, I'm implanting minus 10 diopter of IOL for this particular patient. And this is the pod eye kind of IOL, which is called as a micropure IOL. And we get with this trade only with this much of the minus power. And the maximum minus power which available is minus 15, but I implanted for this patient minus 10 diopter of IOL. And as you can see, the wounds are very well healed. On the post-op day 3, the patient had a very good vision, 6/9 vision with minus zero point 0.5 diopter of error. And now actually, because why I showed this particular case is the biggest challenge was the refractive and biometry challenges, as we know, are very high with these extremely high myopic eye. And generally, we land up with the refractive surprises, specifically the hyperopic surprise. And then you expect IOL malpositioning, decentration due to the large diameter of the capsular bag. And patients, because these high myopic patients are the patients, those who actually come for the freedom from glasses because they have been using glasses for the whole life and they do not want to use these thick glasses now. And they expect clear vision and but if they may end up with a compromised distant and near vision, which is highly dissatisfying for these patients. So your IOL power calculation has to be very, very uh, accurate and particular. But we know that the standard IOL power calculation formulas are unreliable because most of these IOL calculation formulas would give us give us inaccurate oil power, and many times the patients are left with the hyperopic surprise. And so I did was I used this Barrett Universal 2 oil power calculation formula for my patient. And what I did was I actually, because the primary goal in these patients should be like you have to avoid hyperopic surprise. That is the most important. If the patient is left with the undercorrection with myopic power of -2, 3, 4 diopter, also the patient will be happy. If patient lands up with the +2 or 3 diopter or 4 diopter, then the patient is going to have a hell of problem, because he is not going to have a good distance as well as the reading vision. So the primary goal should be to avoid hyperopic surprise. So golden rule in these cases, if the axial length is more than 30 millimeter, always target a little more than -2.5 diopter sphere. So your target has to be -2.5 diopter or more. And there is the adjustment formula also by Bangkok, where the Bangkok formula adjusts the axial length with the corneal curvature as well as the anterior chamber depth, so that adjustment also gives you a little near accurate IOL power. Optical biometry is very important, but while doing the optical biometry, one of the very important point which you should keep in mind is the fixation check. Because generally in these extremely high myopic eye, do yourself optical biometry. Don't leave it to your technician, because you are the one who's going to get the most accurate measurement. And in measurement, the most important point is the fixation check. Your measurement has to be focused on the fovea or macula, because many of these eyes have a stapyloma, posterior stapyloma. If your focus is away from the macula, you are going to get the inaccurate IOL power calculation. And we can use intraoperative aberrometry in some cases where you think like your IOL power to confirm the accuracy of the IOL power. Surgical challenges we all discussed, because they have very deep AC with increased lens iris diaphragm movement, and that is called the lens diverse syndrome. So Dr. Bharti has shown very beautifully that, and Dr. Harshul also has shown that beautiful video. And they have a fragile zonules and thin capsular, and there is always high risk of PCR. Low scleral rigidity with floppy eye leading to fluctuating chamber depth, and the high risk of suprachoroidal hemorrhage. All you have to always keep in these factors in your mind. Liquefied vitreous, so you'll have a lack of vitreous support. So you have to be sure, like while doing the phacoemulsification, there would be a lot of fluctuation of the bag. So keep that also in mind. So how you can control this? Your surgical plan should aim to have a low flow phaco settings. Don't keep very high settings. Keep low flow settings, low fluidics and the pressure to prevent over deepening of the anterior chamber, so that you prevent the reverse pupillary block. Larger capsular axis to prevent capsular phimosis. This factor actually only if you think that the particular patient is going to have a capsular phimosis, then you make a large capsular axis. Otherwise, but don't make more than 6 millimeter of capsular axis. And we discussed about the CTR also. If required, then only you put the CTR. IL selection, single piece or three piece is also has been discussed, but normally I go for the single piece if think that there isn't much of capsular fluctuation. Three piece only if it is required, and always hydrate the wound very well before you close the chamber. And this factor also has been discussed by Dr. Bhupesh. The biggest post-operative surgical challenge in long eyes is the retinal detachment, because we know that these high myopes are at a significantly baseline higher risk, up to at least 15 times than the normal eyes, and surgery further increases this. Younger patients are at higher risk. The risk of rhegmatogenous RD is a primary concern for long-term follow-up in these cases. You have to keep this also in mind. PCR or the YA capsulotomy always increases the risk of the RD almost 15 to 20% again. So preventive measures should be taken like preoperative clearance and treat any symptomatic breaks or lattice 2 to 4 weeks before the surgery. Post-op education, the patient should be educated very well to recognize the flashes and floaters, and they should report immediately if they find these symptoms, and which could be the onset of the RD, and we can protect and prevent the formation of the RD in these cases by educating the patient very well after the surgery. So to conclude, in conclusion, refractive success in the long eye is not a matter of luck. It is a matter of meticulous planning. You have to plan very well. By moving away from the legacy formulas, adopting modern power calculations like Barrett Universal 2, and maintaining a retina-first mindset, we can turn one of our most challenging patient groups into the most satisfying group. Let us remember, in a long eye, precision is the best prevention. So that is what we need to keep in mind and think always. So thank you very much. I'll close my talk here. Thank you.
Thank you, RP sir. Thank you so much. As we are a little short of time, so we'll take Atik's talk, Dr. Atik Sheikh's talk, and maybe then we'll have some questionnaires. Also, Sunil ji, can you please put on the questionnaire on Zoom and YouTube everywhere so that we can get them. Atik,
Yes, sir.
Dr. Atik?
Yes, Saurabh, I'm ready.
Okay, I'll just briefly introduce you, Atik. So Atik is my go-to man too, as always. He's my senior from Chennai. We both did DNB together there. He was an year senior to me. I hope my screen is visible now this time, yeah? Hello?
Yes, sir, it's
Yes, sir.
visible. Yes, sir.
So Atik is one of the managing partners for Fatima Eye Clinic. He's also the academic director there. He is very active with his school organization, as I can read here. So the positions what he's held is he was the chairman ARC for TNOA, and he did a phenomenal Chennai Icon in 2024 as the organizing secretary. And of course, he is also one of my co-LDP and fellow. He's been there everywhere at the ASCRS, WOC, APSCRS, at the AIOS, APO, and given talks in CMEs at the state and national levels. I've always said this, I'm very proud of you, Atik, and it's an honor to welcome you here. He'll be speaking on Phaco in long and short eyes. Just a small request, Atik, be a little fast as we're running out of time. Thank you.
Sure. Thank you so much, Saurabh. Can you stop sharing?
I'll do that.
Thank you for the lovely introduction. We were batchmates, and I'm not sure of what all you told I really deserve, but thank you so much, Saurabh. So we've heard a lot from the experts, so I'll keep my presentation as short as possible. This was a post narrow angle glaucoma patient who'd had a YAG PA done elsewhere. The patient has developed iritis after it and developed posterior synechia. And this was the refraction of the patient was about +8. The axial length was 20. AC depth was shallow and was quite a bulky lens. In these cases, you can see here the PI is quite paid. It was a huge PI. These cases, the incision is something that is extremely very important. You make a narrow incision, the iris will tend to come out, and the iris will already be floppy because it's been handled with the PI, multiple attacks of iritis. So once you touch the iris, you're gone for life. So after the incision is made, ensure not much viscoelastic is injected. You inject too much, again the iris will tend to come out. So I've injected just adequate viscoelastic, going and releasing the synechia. You can see I've released the first one. Second one I'm trying, I'm not able to. You'll be very aggressive. You may end up stripping the capsule also. So I've injected, and now I'm injecting viscoelastic. This is something I hate to see and happened in the worst case. I've ended up injecting too many air bubbles. See, once you inject air bubbles, you'll always tend to inject more viscoelastic to try to push the iris out. It'll tend to push the iris out. In this case, you inject visco, you're gone. So going in with an empty cannula, and I'm actually aspirating the bubbles. Quite a painful task to do, but then these cases, there's no harm in trying to be a little more patient. Rexus, again, you see, even with the Rexus needle in, the iris is tending to come out. So be very gentle, ensure there's not much pressure. So doing a hydro, do mini hydro dissection as discussed by the previous speakers. Tent the capsule, inject very little fluid, tap in the center. That is something that is very, very important. Otherwise, you can rip apart and blow the posterior capsule. So in 2-3 quadrants I've done. So the machine settings again has been discussed in detail. Operate with slightly lower aspiration flow rate and vacuum. Why I prefer a chop in this case, in a vertical chop, you can play in the center. Whereas you want to do a horizontal chop, you have to go towards the equator of the lens and hook it. Already the dilatation is not that great, so you'll be sort of semi-blind doing a horizontal chop. So if you're comfortable, vertical chop is better. You can see here, I'm not even able to get my phaco probe in. It is so shallow. So I've gone in, pushed the iris back with my blunt chopper, and I've pushed the phaco tip inside. You go in just like that, you may end up with the iridodialysis. So I've pushed the iris back. Now I'm clearing the epinucleus and the cortex just to ensure I've got just enough space to get the phaco probe in. And I'm trying to do a chop. It is not that comfortable to chop. It's fairly a soft cataract, so I'm not able to chop it comfortably. Little bit of cheese wiring is happening. So the first quadrant is chopped. Now the second quadrant is done. Now I'm able to get a fairly reasonable chop done. So rotating it, if you see here, I'm not going to the periphery, staying bang in the center. The right hand doesn't move at all. I mean, doesn't move much where I don't go to the periphery. So the sharp chopper goes out and I use a blunt tipped chopper in. The advantage is I can use it as an iris retractor to push the iris away. I hold the nucleus, pull it towards the center, and then complete and do my phaco. I don't want to go to the periphery because you may end up chewing in the iris and it will make the already friable floppy iris even worse. So again here, staying bang in the center, staying way away from the pupil. So visualize, go to the periphery and do. Of course, you can always use iris hooks or a ring in these cases. However, I didn't want to do it because I didn't want to hurt the iris even more. I had it as standby, but I was able to comfortably do the case with ease. So removing the last piece is very important. The AC is shallow, so lower your aspiration flow rate and vacuum even more. I'm comfortable with the bimanual aspiration for these cases because you can use your irrigation as a second-hand instrument to pull the iris away if needed. So to sum up, make a proper incision, have hooks or expanders as standby, operate with lower flow rate and vacuum, do a mini hydro, vertical chop if you're comfortable, and a bimanual irrigation aspiration is my way to go. So phaco in myopic eyes. So biometry is something that's very important, but it's been discussed in extensive detail by the previous speaker, so I don't want to get into it. So let's move further. I just want to show a case. Focusing is something that is very tricky in these cases. You will have to shift your focus from layer to layer and be little patient when that is done. The reason is when you want to make your incision, your focusing has to be on the limbus or the cornea. Then when you want to focus on the capsule, you have to zoom, you have to focus little more because the AC is quite deep and the depth or the levels are a little different, not like your usual cases where you can focus once on the cornea, on the limbus, and then literally you can do the whole case with it. Maybe only when you want to do your IA or something, you have to move your focus a little. But here, layer by layer focusing is something that is very important. And these cases, in myopic eyes, generally the cataract tends to be a little more harder. So playing with your phaco-dynamics is something that is quite important and interesting in these cases. So again, hydro, do a gentle hydro. Don't do a vigorous hydro. It'll tend to blow up the capsule. So mini hydro, tap in the center. I'm able to see that the nucleus is rotating. So I generally don't try to rotate it one more time with the dialer or a chopper. This is something that's very important. As discussed previously, go in with slightly lower bottle height. If you're using equipment where you can control the IOP, keep the IOP little lower. Otherwise, you will tend to cause a LI DRS. Actually, you can see it happening in this case. See, the minute I went in, you can see that the iris lens diaphragm has been pushed backward, and I'm doing the maneuver going in with the chopper and gently lifting the iris, and you can see that the AC is little better formed. It is not that deep. So now I'm clearing the epinucleus, going ahead with the phaco, which is like usual. And the important thing here is when you pull out your phaco probe and your chopper, you have to always inject viscoelastic to ensure that the AC doesn't fluctuate because it tends to cause a PVD and a retinal detachment can happen. The same thing here, I'm going in with my IA. The minute I go in, you can see that the AC is pushed back and sort of LIDRS is happening and the patient is in pain. So I relieve it and then do. So not only for Phaco, even when you do IA, you have to ensure that the maneuver is done and the patient is comfortable. Otherwise, in topical, the patient will be wrenching in pain and make your surgery even more miserable. Thank you, Saurabh. I tried to stick to the 6 minutes which I committed.
Perfect. Thank you, Atik. Thank you so much. As yeah, we were running a little short of time. So very well, both RP sir and Atik, you were also very crisp and sharp, and RP sir also made few extremely good points for the long eyes. So would not take again too long because we've crossed our time. So just one question to you, RP sir. A case
Yeah.
that changed your approach, like we've been taught well, whatever we've been discussing is okay, but something that has happened in the OT and where you said, Kine, this is nothing is working, the approach has to be completely different. And maybe if something, comes to your head. And I think what do surgeons wait too long to convert? Where would you say that, it is gone beyond your hands in these extremely big eyes or
I'll
the
wait for
smaller
sir
ones?
to finish and then come back, Saurabh. Is it okay or you want me to?
Whoever is ready. I have
You
shooted my
prefer?
questions to both.
Sir, you can go ahead, sir, please.
Please, RP sir.
Yeah. See, actually, in these very long eyes, I had one case only once, a long back, not recently. Now we have a much better instrumentation and systems being
Fluidics
used.
and everything. Yes, sir. Agreed.
Previously, we didn't have that good Phaco machines and all. So we had a patient where there was a sudden fluctuation, and then we started having the subchoroidal hemorrhage. And that was the very disastrous complication which I have seen in one of the very long eyes. And that is why I was telling, like, your chamber fluctuation has to be well controlled, and you have to be always in a closed chamber surgery. Like, you should not lead too much of fluctuation, your bottle height and everything. Like, it should not be too high, too low also, so that
Absolutely.
you lose the chamber. And so that was the complication I had, and then I had to stop the surgery and waited for a week, I think, and then we did the surgery again for that patient and successfully.
Perfect.
So one question for you.
Complication has to be kept in mind in a very long eyes. Yeah,
Yes,
so
sir.
one of the very disastrous complication which can happen.
So one question for you, sir. You showed a beautiful capsular polishing anterior as well as posterior. Do you think the incidence of a dead back syndrome or a sick back syndrome will increase whenever we are doing these maneuvers?
Yeah, definitely. This is one of the very important points which has been raised time to time. Like, if you are doing too much of capsular polishing, then you may have this dead back syndrome. But that, as you have seen, but what I was doing, I was not going into the fornix. So this complication may happen if you go to the phonics and then do the polishing, because the phonics should never be polished too much, because otherwise your bag will not give the proper what you can say the location of the eye, because the eye will be freely moving. So it has to have some kind of fibrosis in the periphery. So that is important for the stability of the eye. But what I was doing within the 2 to 3 millimeter of the capsular access margin. So you must have seen very clearly, I was doing on the margin only, not into the capsular bag. So this syndrome comes up only if you do the polishing in the back.
And one more thing, is it a good idea to have a zero point 0.1 millimeter looser wound compared to a tighter wound in these kind of scenarios?
Yeah, wound actually, because if you think, if you talk about the actual wound, it should not be neither tight nor loose. So both the things are important. You should not have to loose wound also, because as you said, like wound, loose wound is going to have a lot of fluctuation, because we know already in these cases you are going to have the AC fluctuation, because the moment you press the foot pedal, the whole iris, whole complex goes back, and the moment you slightly release and it comes back, it kind of fluctuation. And this could lead to problem while you're chopping or doing the maneuvering in the capsular bag, may hit the posterior capsule and may have the PCR, which is again going to be one of the disastrous complication in these very high, long myopic eyes, long eyes. Because if you have a PCR, then it is going to be very difficult to maintain or manage that situation. So neither too tight nor too loose wound is, it should be accurate wound as the size of the phaco probe you're using. If it is 2.8 means then you make a 2.8 millimeter incision only. Yeah.
So Arshul,
Yeah, I think a beautiful presentation by Dr. Atik, and the way we showed that how to take care of LIDRS. Can you hear me now?
yeah,
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 yeah, we
very
can
well.
hear.
Yeah,
So
very well.
the trick to prevent it from happening, what I couldn't show because I didn't have that video now. What I do is when you're going with the phaco probe, before we go inside, because OBD is there, I just tend to lift the iris with the chopper, and so that when I go with the phaco probe, the iris is already tented up. So this doesn't happen. The same with the IA. So when I go with the IA irrigation aspiration, first I go with the aspiration probe, keep the iris tented up, and then start incision. So that in the first place only, patient doesn't feel pain.
Sure.
And of course, if when it happens, you need to relieve it as beautifully shown by Atik also.
So
So I think,
one point I wanted to ask Harshul also,
yeah.
uh, uh, because this patient, why I showed this patient was because, as I said, this had a axial length of 34.5 millimeter, myopia of 30 diopter. And we did the calculation with all sort of calculation, and the average power came up was around 14.5 diopter. 14.5 diopter for this, minus 14.5 diopter for this patient. And but with my calculation, I decided to put 10 diopter. So I did put because there was a formula, the Wang's formula and other formulas. I tried with everything, and it was coming around 11.5 diopter or 12 diopter final. But I did put 10 diopter of the IOL, and because I got the post-op result what minus zero point 0.5. So what do you say like in this situation? If you have a very extremely high myopic, extremely high axial length, more than 30 millimeter, so what should be your correction factor? Because the power the Barrett was giving 14.5 diopter,
So which lens did you use?
micro pure. There is only lens available now at present with minus 10 to minus 15 diopter, not more than minus 15 diopter. We don't have any lens at present. With any trade, it's only micro pure. This is VVI's micro pure, which we have up to minus 15 diopter.
Sir, had you calculated the entire IOL from the ESCRS calculator?
No, no, I didn't use ESCR calculation. I used Barrett, Keynes, and this Olson's.
So basically, in the short eyes and the long eyes, nowadays they say that the short segmented axial length is what is accurate axial length because they go by the refractive index of each of the media that is being gone through.
Right.
So you are going to the ESCRS calculator, they'll ask you whether you are doing an Argus calculation or a non-Argus. If you are
Okay.
doing the non-Argus, they calculate that thing and get that factorization done and give you the exact axial length. So that's more accurate.
I know because ASCRS gives you very good result with post-refractive surgery. But with
The
extremely
ESCRS.
long eyes, they haven't promised the accuracy because they promise very high accuracy with the post-refractive, especially poor RK.
But
Post
this is
RK
not
surgery, they give a
ESCRS.
really very good accurate results. But with very extremely high myopic or high axial length eyeballs, they are not saying like we are going to. Because Barrett says like Barrett Universal 2 is said to be one of the best. The power calculation for the very highly long axial length eyeballs. And we did a Barrett, we did others also because they were almost at the same level, 0.51 diopter here and there. And Barrett gave 14.5 diopter, but my own calculation, and then when I used the Wang's calculation, Wang was saying around 12.5 diopter and 11.5 diopter to 12 diopter. But I did put 10 diopter because what was in my mind, I'll just leave this patient minus 1.5 to
Minus one.
drop myopic. That was in my mind. But post-operatively, I was surprised. Like patient had a minus 0.5 diopter, and he was very happy for the distance, but he was having problem in reading now. So I had to give him the reading glasses. A young girl around 28 years of age. I
I
operated
think,
both the eyes.
is there any other question from any of the moderators? Okay.
I think we can wind up now because I think we're very late running.
Yeah.
Okay, fine. So with this, we come to end of this module 9. Thanks to moderators of this session, Dr. Saurav and Dr. Komal, and thanks to all the speakers who covered this topic so nicely, and thanks to all the expert panel for their valuable insights into this topic. So we'll come with the module 10 on Wednesday, 2:30 to 4 same time. It's really interesting on Phaco in glaucomatous eyes and Phaco in eyes with cornealoplasty. So see you all on next Wednesday. Thank you so
Good.
much for joining in. Thank you so much.
Thank you, sir.
Everyone.
Thank
Thank
you for
you,
the
Thank you,
Anshul.
sir.
opportunity,
Very
sir.
much.
Thank you so much.
Thank you very much. Thank you, everyone.
Bye bye. Take care.
Bye-bye. See you. Okay. Bye.